Thrilled to have Dr. Sándor Lovász with us. For more than a decade as a practicing neurologist and researcher, he is one of the few specializing in diagnostics, therapy, and long-term follow-up for those living with interstitial cystitis, bladder pain syndrome. His focus is on critically reviewing the conventional methods of diagnosis and treatment of IC and working to find or develop new methods, medications, and medical devices in favor of improved quality of life of those who live with this condition. So welcome, Dr. Lovász. We're so happy to have you here today and excited to talk about this wonderful invention, which is going to really change the world for those who need to have installations done. So thank you for this incredible creation. And I'm excited to dive in and talk about it. But maybe first we'll start off with what brought your focus to ICBPS?
Well, I'm a urologist and I was active all over 40 years. And I met time to time patients where I could not explain why they have pain and urgency and frequency where the urine is negative. I did not understand it. I did not know about interstitial cystitis, to tell the truth. But approximately 20 years ago, once I was in a congress where they were speaking on it. And from that time on, I got a real interest in getting deeper into this topic and started to read more and search for literature data and so on. And I could really find more and more patients with this disease. And so I concentrated on this problem and I specialized in this direction. And from that time on, I could diagnose more and more patients. And in all patients, I found the problem that the doctors don't know about this disease. And therefore, I very intentionally try to spread the knowledge about it. I spoke in a lot of congresses about this in our country, and then later on also in international fields. And as I found more and more patients, I tried to make different treatments, and I did not want to just make the same treatment which was published and already usually used in these patients, but tried new ways, new methods, new devices, and so on. And finally, I found a lot of options to improve the conventional treatments of these diseases. And I invented also this tiny adapter, which we are speaking now today about, which we produce now in Hungary. And it's already about 80 years that we use it regularly in patients. And as we started to switch from the aggressive and invasive catheterization to this catheter-free installation method, which let us perform this tiny adapter. We call it Urodapter, which is a tiny adapter placed on the syringe. And by using this, the medical solution, the drug solution, which we use for local instillation therapy, can be instilled through the urethra into the bladder without making any harm, any mechanical damage to the surface of the urethra. And the drug can be instilled into the bladder completely pain-free, with the additional enormous advantage that the drug solution remains on the surface of the urethra as well. So we can simultaneously treat bladder and urethra. And this is the only way we can treat urethra by local installation. So this is basically the principle of this method. Maybe we can go in details in the next few sentences, but basically this was which made me to work in this direction.
So how did it come to fruition? How did you think of creating such a device?
Well, as I told you, the catheterization, which was generally accepted all over the world to perform a local installation therapy, has really a lot of side effects, pain, mechanical damage, sometimes bleeding caused by the surface stretching and damaging of the urethra. And the patients were very much afraid of this way of treatment. And many patients refused the treatment because they had such a high level of pain. You also should know, or maybe you know already, that approximately 70% of IC patients have also pain in the urethra, and not just the bladder pain, as the name of this disease, the bladder pain syndrome, suggests that this is the problem of the bladder. No, in many cases, the pain is also present in the urethra, and in some patients, even the biggest problem is the urethral pain. And if I want to catheterize an absolutely hypersensitive, painful urethra, you can imagine how very, very painful and not liked intervention would it be.
Yeah, I remember my doctor was going to do installations and I refused because I was just so worried. From my experience with a cystoscopy, I just didn't want any invasive procedure being done. And I knew that there would be post effects from it. So when I heard about this, I was just, amazed that you had created such an incredible device to keep it painless. And I mean, so much of the worry and concern of these patients is going to dissipate as a result. So it's really quite incredible.
You know, the feedback of the patients was very positive. They told me if they once get an installation by using this adapter, so in a pain-free way, they never ever let perform a catheterization. I have patients who are traveling from approximately 200 kilometers, I don't know, 120 miles away from Budapest to me to get the treatment by this way, by this method, because their local urologists give it just by the catheter. And the difference is worth for traveling the whole day. So patients really like this, or I can say love this method.
And can people do it on their own, or do they need to have it done by?
Look, theoretically, yes. In male patients, where, male patients have also bladder pain syndrome. That's less known in the population. There's a room, there's the thought that this disease belongs to the women. That's wrong. Approximately the same number of patients we have in male patients.
Wow.
That's less known. Most male patients are treated as a abacterial chronic prostatitis, or if the patient is somewhat elder, then they are treated as a BPH, the benign prostatic enlargement problem. But basically, they have interstitial cystitis as well. So the male patients can be taught to perform such installation with the same device much easier. You know, it's quite easy to understand because they get in the view field much easier, the urethra, the orifice, as in women. But in women, it can be done as well, either in a conventional way, using a mirror and so on. It can be done. It is a little bit more complicated than in male patients, but it can be taught, and it should be taught as well. So nobody can use this adapter when they get first time in the hands and try to do it. There are some tips and tricks which improve the skill of the patient. Mm-hmm. And this is the same for a therapist as well. If a urologist or a therapist takes the adapter and uses for the first time without having any practice or skill, approximately half of the cases will leak. It means the solution doesn't get into the bladder, but flows beside of this adapter into the vagina, which doesn't cause any problem naturally. Sterile drug solution, it doesn't hurt anything, but it's an expensive solution, and it does not get there where it was intended to go. So there are some tips and tricks. This should be known if somebody uses this device, but it can be performed. I just mentioned as an interesting news and a new thing that we developed a special device for women's self-installation. This consists of a tiny video camera, a screen, and this camera is fixed on the syringe, and the patient can look in the screen and sees how the adapter gets closer and closer to the orifice from 5 centimeters, very close, a very good view. And so it can be found and used much easier. Such a device is just a prototype, but approximately 100 patients uses it already in Hungary with very good result, and they are very happy about it. And I have to mention in the COVID era, as nobody could go to the doctor and patient had problem and had to stop the treatment, these patients were very happy and they could treat themselves at home without any problem. So this will come. Now we let it rethink and think and reorganize and replan, and hopefully it will get on the markets quite soon as well.
Why is local installation advantageous? What are the advantages?
Oh yeah, there are many diseases where a local installation has a lot of advantages over systemic, oral, or in any form systemic treatment. Because if we instill the drug into the bladder, then the drug can reach a high concentration on the site of the problem, on the surface of the bladder. Otherwise, if the patient takes the same medication orally, then just a small portion, approximately 5% of this drug gets on the surface. But if we instill it, then we can use a much higher concentration, because it does not get into the circulation, or just a few percent of the instilled agent, and therefore it is much more effective than any other form. Therefore, the local instillation therapy is quite an effective way of the treatment.
Mm-hmm. So I just wondered, I know that you are big on diagnostic tools. What do you usually do to diagnose a patient with IC?
The diagnosis is a really difficult question in ICBPS, and maybe one cause that the detection rate of ICBPS is so low, because the diagnosis is a very difficult problem. We have to exclude every other possible disease which can cause similar symptoms. And there are a lot of gynecological and urological diseases which cause pain and frequency and urgency. And therefore, if we excluded all possible diseases, then we can say nothing else remains, just an option that the patient may have interstitial cystitis. But this is also a suspicion and not a proof of the disease. Mm-hmm. And therefore, we also developed a very easy, non-invasive diagnostic tool for this, which we call it the gag layer test, or the gag layer integrity test. It is based on a urinary diary, a special urinary diary, where we want to look the maximal capacity of the bladder at filling the bladder with concentrated urine on one day. We let the patient drink a limited amount of liquid and measure every maximally withhold amount, the maximal capacity of the bladder, several times during the day. And then at the end of the day, the patient calculates the average volume, what she urinated. And this shows then the capacity of the bladder by concentrated urine. On the second day, the patient drinks a lot, a very enhanced liquid intake, produces a diluted urine, and then we repeat the measurement the same way. Each time when she has to go to urinate, she takes or tries to withhold it as long as possible, and then at the end of the day calculates the average volume. And we compare the 2 days average volumes. If they are close to equal or absolutely equal, but the cutoff value we found is approximately 30% different. If it's less, the difference between the two average portions is smaller than 30%, then we say it excludes any gag layer problem. Yeah. But if it's more, then it proves that there's a problem with the gag layer, because on the first day, the concentrated urine irritates the bladder more than on the second day. This proves that the irritating agents of the concentrated urine can reach the bladder wall. And this proves that the gag layer is not preventing the bladder from this irritation. Mm-hmm. And we look at the difference and calculate it in percent. If it's more than 30%, then gag layer problem is present. And as bigger the difference is, as worse the condition is. So we not just can get a diagnosis of the interstitial cystitis, or better to say, of the ganglion deficiency, but we also can find out the condition of the ganglion. And by repeating this easy to perform, painless diagnostic test time to time, we can also document and see the efficacy of the treatment very objectively. Because if the starting difference was 100%, this means on the second day, the patient had a double volume of the first days. Then we can see that after the treatment, different treatment forms are present, but after the treatment, let's say 6 weeks later, the difference dropped down to 50%, and after 3 months, the difference would be 20%. Then we can prove the efficacy of the treatment very easily and very objectively. So this is a very good method. I hope it will also spread.
Mm-hmm. So do you find that doing this instead of a cystoscopy under hydrodistension is more, like, are you all about being less invasive and causing less harm to the patient's bladder? Is it instead of a cystoscopy?
Well, a cystoscopy is not a diagnostic tool. Mm-hmm. Even if we make the cystoscopy and we see HANA lesions inside the bladder, that's the proof, naturally. Then it was a diagnostic tool. But in many cases, in IC patients, we don't see any positive picture of the bladder if we perform low pressure cystoscopy. So in many cases, we don't need to perform cystoscopy, because what we should know if the patient has HANA lesion, may stone, any other problem, and first of all, any malignancies we have to exclude. But the malignancies which cannot be seen on ultrasound or MRI or any other radiological diagnostic procedures, then the only option remains the so-called carcinoma in situ. This is the CIS, which is a very tiny, in many cases, microscopic superficial malignancy of the bladder. And this cannot be seen in many cases on the cystoscopy as well. Therefore, urine cytology is much more effective and naturally non-invasive way. We let perform it in each cases of the patients, and we perform the cystoscopy only if we see some suspicion of malignancy on ultrasound, or the patient has blood in urine. Then we perform the cystoscopy. But this is then, in a first step, a low pressure cystoscopy. Mm-hmm. And if the patient gets already a treatment for oral treatment, let's say a combined oral treatment for IC, and it does not improve the condition, then we perform a high pressure cystoscopy, which means in an operation theater, in general anesthesia, we perform 80 centimeter of water pressure cystoscopy. And then when we see the typical signs of IC, bleeding, some herniations or ruptures, or any unused or unnatural or not healthy signs of the bladder surface, then we coagulate it at the same time. Therefore, the high pressure cystoscopy is always performed in the operation theater, and in case if we find some problem, then we can solve it as a endoscopic operation immediately.
Okay. So we were talking last week, and you told me something very interesting about citric acid. So, and I thought this was a great point. I put it in my support group, and I thought it'd be great for you to share what you recommend for those who struggle with nocturia, which is nighttime urination.
Oh, yeah. Well, citric acid is maybe the only exception of the acidic meals which alkalinizes urine. And this is a very positive effect, because the acidic urine irritates the bladder the most. Acidic is urine if it's theoretically, naturally, if it's less than 7, then it's already acidic. But in the clinical practice, we see that it irritates the bladder only if the pH value is less than 6. Then we say that the patient has the acidic urine, and it should be treated, it should be prevented. The diet is one option, how we can prevent acidity of the urine, but we also use alkalinizing agents. And most of these agents use citric acid and different citrate salts, sodium citrate or magnesium citrate, or in many alkalinizing agents there is potassium citrate as well, because it very quickly and very nicely prevents acidity. But the problem is then if somebody takes such a potassium citrate drug or preparates, then the potassium concentration of the urine elevates as well, and the potassium is the most irritative agent in the urine. So we don't use, therefore, potassium citrate. But citric acid is positive. And therefore, we also say to the patient they should take this citrate alkalinizing tablet for the night, because during the night, as the urine gets more and more concentrated, if the patient does not drink during the night, as usually patients don't drink during the night, the urine will be at the morning hours already very irritative, not just because it is concentrated, but at the same time it will be more acidic. And therefore, taking this alkalinizing tablet for before going to sleep, it can help preventing the acidity in the early morning hours. But at the same time, we also advise to the patients to drink liquid during the night. But the patients say, oh, how should I drink? If I drink, then I go even more frequent to the toilet during the night. I have to go anyhow 4 times. If I drink more, then I would go 8 times. And that's not right. If the urine gets more diluted, it won't irritate the bladder, and the patients would observe that despite of the more liquid they drink, they will go less frequent to the toilet in the night. And that's very, very important, because if they don't drink during the night, let's say for 8 to 10 hours, then the urine in the early morning hours will be so concentrated that each time or each day, the day starts with an irritation already inside the bladder. And this regular irritation of the bladder leads to stop, to prevent the gaglia production in the bladder. So if we can reach that the bladder does not irritate every day and gets non-irritated, naturally that's just one side of the treatment, but can help to reach a better gaglia production.
Good to know. I think that's probably new information for a lot of people who struggle with IC out there.
Yeah, I always say to the patient, if you go to the toilet 3 times a night, that's great, because then you have an option to drink 3 times during the night. And each time, before you go back to sleep, drink 200 milliliter water. If possible, some lemonade, some citric salt in it, or citric acid in it.
Not the juice, not lemonade, sugar.
It really
lemonade,
helps.
Yeah, you said half a lemon, squeeze it into the water.
Yeah.
And that is what Dr. Lovász calls lemonade.
And they should optimally prepare it during evening hours, and not try to find the lemon and prepare this lemonade during the night, because then very likely they won't be able to go back to sleep or won't sleep again. But they prepare it and let it in a glass to set on the table, and when they went to the toilet after it, they drink it immediately, and they can keep on sleeping.
So are there any new tools other than, I mean, obviously the Eurodopter is now available in North America, both Canada and the US. Is there anything else underway for IC patients that you've been working on? Diagnostic tools or
yes. Well, this is the urinary diary, 2 days urinary diary. This is the gaglia integrity test, which can be found on our home site, description for it on our website, eurosystem.com website. It is not dangerous, you know. Anybody can try to use it to follow up their condition for themselves. From diagnostic side, this is what we hope it will spread. About the treatment, we find that monotherapy is any type of monotherapy is not enough in ICBPS. So we always need to give combined treatment. This means to combine options or different treatment forms which helps. So we always use diet. Diet plays a significant role in ICBPS. I do not agree with those suggestions, recommendations where 200 different meals are forbidden to take, or the patients get very confused and say, what, I cannot eat anything anymore. That's not good. We just suggest to eliminate the most irritative agents, And this is very, very simple to list. This is alcoholic drinks, caffeine in any form, spicy meals, vinegar, and tomato. So this is what they have to absolutely try to leave out. And many fruits, because the fruit have many foods have acidity, acidic, but there are some exceptions like banana,
pears,
pears and water lemon, which are very liked by the patients usually. So diet, then liquid consumption. Our diagnostic test proves that the diluted urine helps to prevent irritation of the bladder. Therefore, we recommend every day minimally 2,500 milliliters liquid should be drunk, and approximately 500 milliliters during the night out of it. Then we use the alkalinizing diet and alkalinizing tablets for the patient, and also some compounds of the gag layer compounds. These are hyaluronic acid, which can be taken orally as well, and chondroitin sulfate. These are the most important compounds of the gag layer. This can be taken orally as well. And if the patients takes all of these and the result is not enough, in these cases, we recommend the instillation therapy. And our drug solution, which we use, is containing from local anesthetic, some lignocaine or lidocaine, some steroid, which we instill into the bladder, and gag layer compounds and heparin. But these solutions are not given as a one shot, because we found if we first give lidocaine or lignocaine in a 2% concentration, then we can anesthetize the bladder and wait 3 minutes. And after the 3 minutes, we instill the heparin, chondroitin sulfate, and hyaluronic acid. Then the patients are able to take it inside the bladder much longer, for a much longer period, about some patients for 3 hours. And that makes a huge difference if the patient can keep inside the bladder for 20 minutes or for 2 hours, for 30 minutes or for 3 hours. That the difference is made by the lignocaine pre-treatment. So this is our diagnostic or treatment protocol. And I have to mention the huge importance of the follow-up of the patient. Continuous monitoring these patients for years, in some cases for decades. I have now also for a few patients who are treated and continuously followed up for more than 10 years already. And they like it. They like this connection with us. And this connection was made possible by a special program over the internet, where the patients regularly send their data, their questionnaires about their condition regularly to us, and this builds up a database which is very effective and can be used for statistical evaluation as well.
That's amazing.
And these data builds up a graph, and on this graph we can visually see and follow the patient's condition. And this is really objective and very useful, because otherwise the patients usually orally would report, and they never can objectively report. And they say, oh, you know, my doctor, in the last months, I think it was, I thought it would be a little bit better than it was. So it is impossible to evaluate such reports. But if they send their objective, measurable data, questionnaires and urinary diary data to us, then we can keep our eyes on the patient's condition. And it's very important, because we see every important events. We see the flare-ups. We can maybe we can also prevent some flare-ups if we know already, based on this follow-up, when such a flare-up is to expected.
Mm-hmm. Well, wow. Thank you so much, Dr. Lovász. It's amazing that you're doing this work, because as an IC patient, you know, there aren't enough of you out there. And what you've created for the community, you know, this Urodaptor, it's so exciting that it's finally coming to our side of the world. It's going to make a huge difference for patients. It's groundbreaking, and I just can't wait to see, you know, how it changes for patients to have this opportunity to use this tool. It will also take a lot of stress out of patients as well, which could exacerbate the bladder symptoms. So thank you so much. Thank you for coming on here today and letting us know all about, you know, the Urodaptor and your diagnostic tools and everything else you've filled us in on, the nocturia remedy, the diaries. And like you said, I'll put up the website so that people can access that as well. And again, thank you so much.
I thank you so much being invited for this discussion, because it's really important to speak about this problem a lot, because maybe it's easier to spread the knowledge among population and among patients than among doctors. So it's also very, very important to speak about it and in a very understandable way, not just in high congresses, but for many, many patients. They should know that this disease does exist, and it exists also in many, many cases in male patients. And it is very few spoken about it. So it's also important that male patients can think on it if they get the diagnosis of a non-bacterial chronic prostatitis, and it is treated already over years without any efficacy, then they should simply try to perform a gag-layer integrity test. And if it proves the disease, the problem, then they should turn to a specialist of urology, a urologist.
Yeah, the stats are, I mean, it says over 90% of it's female centric, 92%, I believe. So it's just obviously wrong.
It's terribly wrong.
Yeah.
Yes.
Yeah. So hopefully we see a change in that in the very near future. Those stats.
Poor male patients should be also treated.
Absolutely. Absolutely. All right. Okay. Well, thank you again. And, if anyone has any questions, feel free to leave them in the comment section. And And I will say goodbye, and we will
Thank you.
speak again soon.